Start, sir.
Yeah.
Yeah.
Good evening, doctors. Warm regards from Bayer Oncology. Thank you for joining tonight discussion on prostate cancer. So today we have Dr. M. Ravikrishnan. Sir is a medical oncologist from Medical Hospital, Nanakrampura, Hyderabad. Sir, over to you.
Yeah. Thank you. Thank you, Sandeep. And thank you, Dr. Deepthi and Dr. Shravan for joining. So we know like metastatic CA prostate is a challenging case to disease to treat because it is the most common mortality. The majority of the mortality happens in the prostate because of these metastatic cases. And we have come a long way in this management of the metastatic CA prostate. So from the sequential hormonal therapies to the upfront triplet therapies. So thanks to multiple studies like the recent one, the ARASENS and the ARAT-NOTE, now we are measuring survival in years rather than months. So there are multiple guidelines out there like how to manage these metastatic cases like hormone sensitive, high volume, low volume. But what I feel most important is like having perspective from the different consultants. So that is more important. So like how we deal in a day-to-day basis and what is the perspective of a consultant who is treating those cases. Those are more important than the guidelines. So with that thing, so I would like to introduce, ask Dr. Shravan so to present his case and give his inputs on the management of this metastatic HSPs. Over to you, Shravan.
Thank you, Dr. Kavi. So today I will be presenting iron trial, which made darolutamide darolutamide to use in first line of metastatic hormone sensitive prostate cancer. Let me share my slides. Am I audible and clear?
Yeah, yes, Shravan.
Yes, sir. You are audible and clear, sir. Please proceed. Yeah. So these slides are given to me by Bayer, and I don't have any conflict of interest. So as we all know, prostate cancer, majority of the times it is diagnosed locally or in the locally advanced stage. Once it is diagnosed, we either treat with complete radical surgery or radical radiotherapy or observation, depending upon the stage and survival of the individual. So after this initial stage of treatment, there will be biochemical recurrence in evolution of prostate cancer. And once the biochemical recurrence is there, we either treat with ADT or when along with biochemical recurrence, there can be metastatic hormone sensitive prostate cancer. So once in metastatic hormone sensitive prostate cancer or in biochemical recurrence, we usually treat with ADT. And once ADT is given, later again it evolves into either metastatic CRPC or non-metastatic CRPC. And ultimately, patient dies usually if there are no comorbidities and patient usually have survival of more than 10 years. Patient can die due to CRPC, which CRPC itself can cause death. So patients who suffer and die of prostate cancer, usually all of them have CRPC. And whatever treatments we have now, in the case of CRPC, OS improvement is approximately 2.5 to 4.5 months. So it is important for us to treat CRPC or prostate cancer in the early setting so that evolution into CRPC is delayed and subsequently overall survival. So initially, when after placebo, when ADT was given, this is the survival chart which is with ADT compared to that of placebo. The median here we can see it failure-free survival and overall survival with ADT. So the failure-free survival is approximately 11.2 months, whereas overall survival was 4.2 months only with ADT. This is the first step after placebo, which improved survival. And after this, again, there are multiple choices of therapy. Radiotherapy was tried, and later PK, hormonal therapy, and chemotherapy. So first of that is radiotherapy. Trial was done to see whether addition of radiotherapy to local disease after local disease would help or not, along with ADT. So in low volume disease, if bone mets are less than 4, if radiotherapy is added to the local prostate gland, there is significant improvement in failure-free survival and overall survival with hazard ratios of 0.6 and 0.56 and 0.64. Whereas if the volume of disease is high and if there are greater than or equal to 4 bone mets, there is no benefit in failure-free survival and overall survival. So these are the trials which have shown evaluation of treatment in metastatic prostate cancer. So first, the docetaxel was used along with the ADT in the metastatic setting. The trials which evaluated docetaxel are JET, UG, AFU15, Charted, and Stamped. All these trials together established docetaxel as standard of care along with ADT in high volume disease with hazard ratios of 0.8. And trials like Stampede and Latitude established abiraterone as standard of care with hazard ratios of 0.6. And studies like Archies and Enzamet established enzalutamide as standard of care. And Titan evaluated apalutamide. And other trials which evaluated triplets are PIS1 and arasinus. So let's see each of these trials individually. This is the Charted trial where docetaxel was evaluated along with ADT in metastatic hormone-sensitive prostate cancer. If you see in low volume disease, this addition of docetaxel to ADT did not significantly improve overall survival, and the hazards are 1 with no p-value, no significant p-value. Whereas in high volume disease, addition of docetaxel to ADT significantly improved overall survival with the median survival of 50 months compared to the 34 months with ADT alone, with hazard ratios of 0.6. There was improvement of approximately 16.8 months with addition of docetaxel to the ADT. In the Latitude trial, where abiraterone was evaluated, particularly in high-risk disease, it improved overall survival to 53.3 months along with ADT compared to that of placebo, where it is 36.5 months, with hazard ratios of 0.66 with significant p-value. However, though abiraterone was the first hormonal treatment which was effective, it is important to understand other side effect profile and secondary endpoints also. Definitely, there was overall survival benefit and other secondary endpoints like pain progression, skeletal-related events, and prostate-specific antigen progression was delayed in abiraterone arm. However, if you see side effect profile, in the arm where abiraterone was used along with prednisolone, hypertension, hepatotoxicity, hypokalemia, and cardiac disorders were high compared to that of placebo arm. Even when it is used in later lines also, these side effect profile were higher. Coming to this is only in high volume disease. Abiraterone showed benefit only in high volume disease. Coming to Titan apalutamide trial in metastatic hormone-sensitive prostate cancer, when it was compared with placebo along with ADT, in low volume disease and high volume setting, it has significant benefit with hazard ratios of 0.36 in low volume disease and 0.53 in high volume disease, and with significant p-value. So coming to the enzalutamide in metastatic hormone-sensitive prostate cancer, again, progression-free survival hazards were 0.4 with significant p-value, and overall survival hazards were 0.67 with significant p-value. It showed benefit in both low volume and high volume disease. So until here, what we have basically the summary is abiraterone and docetaxel showed benefit only in high volume disease, whereas enzalutamide and apalutamide, they have significant clinical benefit even in low volume and high volume disease. But the important point to consider is side effect profile, especially with abiraterone. It has significant side effects of hypokalemia, hypertension, and cardiac abnormalities. Whereas with enzalutamide, it is it significantly penetrates blood-brain barrier, causing cognitive dysfunctions and increased risk of seizures also. Whereas apalutamide has significant side effects of rash and hypothyroidism. So the benefits are seen with all drugs, but side effect profile is different, and the clinical context of using these drugs may vary. Coming to the triplet regimens, where in PIS1 study, first triplet was evaluated. In this, in a hormone-sensitive prostate cancer who had de novo M1 disease were included without prior chemotherapy or recurrent M1 disease, which were stratified based on the performance status and high volume, low volume disease, who were randomized to basically standard of care, which is ADT, along with docetaxel. Initially, there was no docetaxel in the standard of care arm. However, when started Stampede trial and Chartered trial were done, and docetaxel became the standard of care, the trial was amended to add docetaxel to the standard of care. So ADT and docetaxel were the standard of care compared along with abiraterone and abiraterone plus radiotherapy. So when abiraterone was added to the standard of care in high volume disease, we can see here definitely there was improvement in overall survival in high volume disease, with median survival of 5.1 years with in abiraterone arm compared to that of standard of care. It's approximately 3.5 months, with hazard ratios of 0.72 and significant p-value. However, in low volume disease, both the arms performed well irrespective of addition of abiraterone. So this led to the confirmation that in high volume disease, definitely triplet regimen works, and in low volume disease, it did not show any significant benefit. So this led to the design of dolutamide with docetaxel. This is and that is ARASEN study. This is a global randomized double-blind placebo-controlled phase 3 trial where metastatic hormone-sensitive prostate cancer patients were included, and they were stratified according to the ECOG performance status, metastatic disease, and alkaline phosphatase levels. And here the placebo was compared with dolutamide, and the primary endpoints were overall survival, and multiple secondary endpoints were there. So 87% of patients received all 6 cycles of docetaxel, and adverse events were comparable between both the arms. So coming to the overall survival, here we can see in this chart, there is early divergence of the curves, and we can clearly see the median has not reached in the dolutamide arm after 5 years of median follow-up, and whereas it is 48.9 months in standard of care arm. And at the end of 5 years, 63% of patients did not progress in dolutamide arm, whereas 50% progress in placebo arm, with the hazard ratios being 0.68 and clinically significant p-value. So benefit was seen in all subgroups, irrespective of low-risk disease and high-risk disease. We have seen earlier that in phase 1 trial, in low-volume disease, there was no significant improvement with that triplet. But however, with dolutamide, when used along with docetaxel and ADT, there is significant benefit even in low-risk patients with significant hazards value compared to that of high-risk patients. So these are the key secondary endpoints, which are time to development of castrate-resistant prostate cancer, and first subsequent antineoplastic therapy, pain progression, and first skeletal related events, all have definitely shown significant benefit or significant improvement with the dolutamide and standard of care compared to that of only standard of care. So along with these benefits, it has also seen that the levels of PSA the levels of PSA have deepened response with dolutamide arm. Here we can see that in standard of care, at 24 weeks, nearly 25% of the patients had achieved or disappearance of PSA, whereas with dolutamide, you can see progressively there is increase in the disappearance of PSA in patients who are on dolutamide. So it was also subsequently analyzed whether if PSA progression or time to PSA progression, if PSA is disappeared at 36 weeks, how is the progression? That is also analyzed. So if PSA has disappeared at 36 weeks, there is significant failure-free, event-free survival compared to that of detectable PSA at 36 weeks at 36 weeks. And the same is again analyzed in overall survival. if PSA was not detected at 36 weeks compared to that of detected at 36 weeks, we can clearly see the curves diverges at 1 year, and the patients who did not have any PSA detected have significant overall survival compared to that of patients who have detectable PSA at 36 weeks. Again, this is the same, which is in high volume disease. It is again showing the same thing. Basically, there is deeper responses with dorolutamide. Even the continuation of dorolutamide over time, the response is continued, and PSL levels becomes undetectable with time compared to that of standard of care. And again, in high volume disease, this event-free survival and overall survival are better if PSA is undetectable at 36 weeks compared to detectable PSA. And the same is seen again in low volume disease. And these are all subgroup analysis which are not planned, but they have significant hazard ratios. And the curves are clearly divergent. And though it is a subgroup analysis, it is difficult to ignore such good curves divergence in Kaplan-Meier curves. So after all these, after seeing the initial trials with hormonal therapy and triplet therapy, things to ponder upon after this are basically we should, when we are designing treatment, we should understand whether our patient is able to tolerate and accept docetaxel, and we should decide the treatment based upon the high volume disease and low volume disease. And we also have to consider age and life expectancy of the patients and its comorbidities and polypharmacy, all those things will in near future, if depending upon the patient characteristic, is docetaxel be an obligation if another generation hormonal therapies comes. The need for docetaxel might just be an obligation. We don't know exactly. Future trials will decide on that, and we should consider patient should be given all options depending upon. We should explain every side effects and event-free survival and overall survival of the trials which we know, and let the patient. We should give after giving detailed information. We should also give importance to patient decision and choose the treatment. Thank you.
Thank you, Shravan. Now I would like to invite Dr. Lakshmi Deepti to present on ARANOTE.
Good evening, Dr. Shravan, Ravakrishna, and others. Slides will be shared from your side, or should I share them?
If possible, please share it from your end. If not, then I'll request my colleague to do it.
Okay. Is it visible?
Yes, ma'am. You're audible and slides are visible, ma'am. Please proceed.
Good evening, everyone. My talk today would be with on the ARANOTE trial, which is the comparison of the darolutamide with ADT versus darolutamide versus ADT alone. As Shravan sir has mentioned, in the treatment of metastatic hormone-sensitive prostate cancer and CRPC, the treatment evolution has been very long. Since 2014, many drugs have been introduced, showing further improvements in the survival and also further decrease in the PSA progression and the progression to the metastatic CRPC. So our main topic today would be on the role of the darolutamide in these patients. The main problem with the prostate cancer patients is that usually all the patients are very elderly, and they will have other comorbidities. They'll have either hypertension, diabetes, or any other stroke-related conditions. So they adding any toxicity to them with other drugs is very bad. So we need some drugs which are having less toxicity, more tolerable, and which increases the survival of the patients. Initially, in the ARASENS trial, it was seen that when darolutamide was combined with docetaxel, there was increased overall survival. So further a study was done where we can omit docetaxel for the patients who are of borderline performance status, who are of having low volume disease. Maybe we can remove the docetaxel, and if still the benefit is there or not, we want to see. So darolutamide in combination with ADT was studied in the ARANOTE trial. Based on the ARASENS, darolutamide with ADT with docetaxel is the standard of care for the metastatic hormone-sensitive prostate cancer. In ARANOTE, we have decided to see if The effect is there even without docetaxel, if we can omit the chemotherapy arm. For this study purpose, the total population was taken around 665 patients. We have selected metastatic hormone-sensitive prostate cancer with the stratification done on the basis of the presence of visceral mets and if there was any prior local therapy. The randomization was done in 2:1 arm, with one arm patients receiving daralutamide with ADT and with the other arm receiving only placebo plus ADT. The primary endpoint of this study was radiological progression-free survival, while the secondary endpoints being the overall survival, time to CRPC, time to PSA progression, rise of the undetectable PSA, the time to pain progression, and the safety. Later, if the patient has progressed on the placebo arm, they were allowed to cross over to the daralutamide arm, for whom the overall survival and safety was measured. As we can see, the study done contained around 32% of Asian patients. So it is more comparable to our patient population. And it included both Asia, Latin America, and Europe. And coming to the metastatic status, around 70% of patients had metastatic as baseline, whereas 22% patients had metastasis in the follow-up. And the disease volume, around 70% patients were high volume disease. Usually we assume that if patient is having high volume, we need to give chemotherapy. But in this trial, the total patient population showed around 70% with high volume, in which we are omitting chemotherapy and seeing how the response is there. So compared to other trial, the Arano trial has people from all over the world, having majority of population from the Asian subcontinents. So coming to the results of the trial, this is the graph showing the PFS comparison. It was seen that when daralutamide was given along with the ADT, the median PFS was not reached, whereas with placebo, the median PFS was around 25 months, showing a significant difference with daralutamide arm with a hazard ratio of 0.54%. Coming to the subgroup analysis, as I have mentioned, disease volume is a major important factor. And we can see that in the high volume disease, the median PFS was 30 months, whereas it was 19 months with the placebo arm, whereas in the low volume disease, it was not reached. Even in among the other stratification also, daralutamide has shown to be a better response compared to the placebo. Coming to the secondary endpoints, the overall survival was not reached in both the arms, whereas the time to CRPC was not reached with the daralutamide arm. It was 13.8 months in the placebo arm, and the time to PSA progression was not reached in the daralutamide arm compared to 16.8 months in the placebo arm. And the time to initiation of the second line therapies was also not reached in the daralutamide arm compared to, and also not reached in the placebo arm, whereas the time to pain progression was 29.9 months in the placebo arm compared to not reached in the daralutamide arm. We did not evaluate the overall survival as the data was immature. And it has been seen that the time to conversion to the metastatic CRPC was significantly prolonged in the daralutamide arm. As we can see in this graph, the median has not been reached in the daralutamide arm, whereas with the placebo, it was only 13.8 months. And coming to the time to pain progression also, the median was not reached in the daralutamide arm. With placebo, it was 29.9 months. Delays in time to pain progression is highly important to patient. It has not been seen with any other AR inhibitors also. Coming to the suppression of the PSA level, it was seen that the PSA was significantly suppressed with the daralutamide arm, which is less than 0.2 nanograms per ml at any time during the treatment compared to the placebo arm. And the time to PSA progression was also not reached in the daralutamide arm compared to the placebo arm. This is the comparison of the responses in the high volume and the low volume disease, which I have mentioned before. It was shown that both high volume and low volume diseases had shown significant benefit with addition of daralutamide compared to the placebo with the ADT. So what the second line therapies which the patients have received in this arm who has received daralutamide are the docetaxel, etoposide, enzalutamide, apalutamide, cabazitaxel, olaparib, and the radium nucleotides. Coming to the treatment related adverse effects, the adverse effects were almost similar between the two arms. Only 6% of the patients had led to discontinuation of the drug, but it was not significant between the two arms. The median treatment duration was around 24.2 months in the daralutamide arm compared to 17 months in the placebo arm. And the safety profile was independent of the PSA response and consistent with the tolerability seen in both the other trials. The main side effect which we consider with the androgen receptor inhibitors is the fatigue and the CNS toxicity. As we can see, compared to the daralutamide arm and the placebo arm, the fatigue was not much high. It is 5% in the daralutamide arm compared to 8% in the placebo arm. Compared to other side effects, all were similar between the two arms. The addition of daralutamide did not show any significant increase in any major toxicities. So these are the various side effects which are usually associated with the androgen receptor pathway inhibitors, which are similar between the two arms. Coming to the quality of life scores, the quality of life was measured using the FACT-P scores, and we can see that the deterioration of the quality of life was delayed with the daralutamide arm. When we are using daralutamide arm, the quality of life is deteriorated late by around 5.1 months. So there is main delay in the pain progression and also delay in the deterioration of the overall well-being of the patients. To conclude, daralutamide plus ADT has significantly improved the progression-free survival in patients with metastatic hormone-sensitive prostate cancer, making it one of the treatment options for patients who are of borderline PS and who cannot tolerate the chemotherapy. Daralutamide has also shown a benefit alone across all secondary endpoints. It is associated with deeper PSA response, that is less than 0.2 nanograms, regardless of the baseline PSA, and it is the only first AR inhibitor to demonstrate clinical meaningful delays in the pain progression, overall well-being, and also the urinary symptoms, functional well-being. The main advantage of daralutamide over the other AR inhibitors is the favorable safety profile. So daralutamide plus ADT without docetaxel is an additional standard of care option for the metastatic hormone-sensitive prostate cancer. The other advantage of daralutamide compared to the other AR inhibitors would be its less drug-to-drug interactions. So in majority of the elderly patients who are already on multiple drugs for multiple comorbidities, daralutamide has less drug interactions, making it a good option for them in whom we cannot give chemotherapy and who are having high volume disease, as it has shown significant responses. Thank you.
Thank you, Deepti, for your elaborate talk on the RNO. So now, after listening to these trials, now I will present a case and then discuss the practical implications, like so what to do in a day-to-day practice, what are all the questions we will have in our practice when a patient comes to in our OPD. So we will deal those things. Am I audible, Shravan?
Yeah.
The slides are visible, right?
Yes.
Yeah. So I'm Dr. Ravi Krishna, medical and hemato-oncologist, now working in Medical Hospital Financial District. So this is the case which has been presented to me some like 2.5 years back. So 65-year-old male patient who is a diabetic and hypertensive, well controlled. So there is no end organ damage, like no nephropathy, no retinopathy kind of thing, and no peripheral neuropathy. And patient has been evaluated for the complaints of low backache and lower urinary tract symptoms for the past 6 months. So on initial evaluation, because of the low backache, MRI spine has suggestive of like multiple lumbosacral vertebral mets are there and iliac bone mets are there with multiple para-aortic nodes. So then PSA has been done, which has shown like a value of 28. And the biopsy from the prostate came out as adenocarcinoma histology. with a Gleason score of 4 plus 5, that is 9, and the grade group was 5. And then the MRI prostate was done, which has shown mass in the prostate, which is infiltrating the adjacent levator annex. There are multiple nodes or there, conglomerated lymph nodes are there in the pelvis and the abdomen. And the largest one is approximately measuring 4 into 2 centimeter along the right internal iliac. And along with that, there are multiple lesions in the pelvis and bilateral femoral head and neck. Then we have done the PSMA PET scan. So this is the scan. So we can see that there is a prostatomegaly with intense PSMA avid uptake. And along with that, multiple retroperitoneal lymphadenopathies are there. And the largest one is like obturator of 6 centimeter. And there are multiple skeletal mets are there. So you can see it is entire vertebra has been involved, and there are multiple ribs are involved, the humerus and the femur, pelvic bone. So multiple bone lesions are there. So coming to the impression, so he is a 65-year-old male, hypertensive and diabetic, metastatic hormone-sensitive prostate cancer. Index PSA was like 28. Histology is adenocarcinoma, and the Gleason score is 9, and the grade group of 5. So if you go by the classification, like charted as per the charted and latitude study, it belongs to high risk. He belongs to high risk group because there are more than 3 bone mets are there, and the Gleason score was more than 8. And he belongs to high volume because there are more than 4 lesions. So not 4, there are like multiple lesions are there with one outside the vertebra and pelvis. There are majority outside the vertebra and pelvis, like ribs are involved, the femur was involved. So he belonged to high risk and high volume. So coming to the management. So whenever we see these kind of patients, the first question I will ask to myself was like, so what is the risk of the patient? So whether he belongs to the high risk or low risk. And then the second question was, what is the volume? Like whether it is like high volume or a low volume disease. And the third one was whether it is a synchronous disease or a metachronous disease. So because these are very important in the management, so let's see like how these knowing this nomenclature is very important. So if you see, like as I mentioned, we will divide it into high volume or low volume. High volume is classically defined as like more than visceral metastasis should be there, 4 or more than 4 metastasis should be there, bone metastasis, and 1 should be outside the vertebral column and the spine. And high risk includes 3 out of 3, any 2 of should be present, either visceral metastasis, 3 or more bone metastasis, and Gleason score 8 or more. So this is the classification which we will use for the low volume and high volume and low risk versus high risk. So if you see the prognosis of this patient, the metachronous and the low volume are the best patients, and they have a median overall survival of almost like 7.7 years. Okay, and when we see the de novo high volume cases, the median overall survival is approximately like 3.6 years. So for this reason, we need to understand like what is the prognosis of the disease based on whether it is a low volume or high volume, whether it is a synchronous or metachronous. We can at least identify what is the prognosis of the disease. The next question would be like how to decide, like whether we need to give doublet to this patient or whether we need to give triplet. And if we are choosing triplet, what regimen needs to be chosen, whether we have to choose the piece with abiraterone or whether we have to choose the aracens with the darolutamide. So as like Dr. Deepthi and Dr. Shravan has told, so there is a data for the both. Okay, so but how to choose this regimen on a day-to-day practice? So generally, I will divide my patient into 3 categories: whether the patient belongs to good prognosis, true prognosis, or the intermediate prognosis. For example, like if you look at the good prognosis patient, that is a metachronous low volume disease. In this one, why we are calling good prognosis was because the overall survival in this patient was almost like 92 months, and there is a longer time to CRPC, that is almost like 25 months with ADT alone actually. So in this group of patients, chemotherapy appears to provide very little benefit for this patient with prior local therapy and low volume disease. So these are the group of patients where you can conveniently avoid the chemotherapy. Metachronous, low volume disease, ADT with ARPI would be more than sufficient. No need of docetaxel chemotherapy. On the other end of the spectrum, if you see there is a poor prognosis disease, that is synchronous and high volume disease. So for patients with de novo high volume disease, it is hypothesized that the disease may be less reliant on the testosterone, making the addition of chemotherapy on top of the ADT plus new hormonal agents a more effective treatment scheme. So these are the kind of patients, because there is no dilemma in this one. If the patient has a synchronous disease, if the patient has a high volume disease, so it is better to add chemotherapy. It is better to give triplet therapy, and which triplet we will deal with in the next slide. But for synchronous high volume, triplet; for metachronous low volume, only ADT plus ARPA. The question comes like, what about the intermediate prognosis patient? What if the patient has a metachronous high volume disease or a synchronous low volume disease? So in this one, if you go back when Shravan has presented the charted trial, it was mentioned that in the charted trial, in the low volume disease, there is no benefit for the docetaxel. Okay, that is an overall analysis of the low volume disease. But if you dig deeper into that low volume disease analysis of the docetaxel, there is a clear difference. When the patient has a metachronous low volume disease, there is no benefit with the docetaxel. But when there is a synchronous low volume disease, there is a benefit with the docetaxel, because that study has given an overall picture of the low volume disease, and majority of the patients are metachronous low volume. That is the reason that docetaxel has not shown any benefit in the charted trial. But remember, even in the low volume disease, docetaxel has a role if it is a synchronous. But if it is a metachronous low volume, docetaxel has no. So with this thing, like intermediate prognosis patients, how to choose was good prognosis, only ADT plus ARPA. Poor prognosis, triplet regimen. Intermediate prognosis, how I will decide was, whenever a patient is fit for docetaxel, I would push for the triplet regimen. But if the patient is not fit for the docetaxel, then I would choose the ADTF doublet regimen. So this is the kind of approach in a clinical practice, like day-to-day approach I will follow. But whether these things are sufficient, like knowing high volume or low volume, whether synchronous or metachronous, so I don't think so, because we were a lot of times we were in a dilemma, even if we know whether it is a low volume or high volume, whether to give triplet or doublet. Then how to decide was, there are multiple other factors which we should look into. So some such factors are like age and life expectancy. So we should know like what is the age of the patient we are dealing with, whether it is like 60 years, 65 years and 70 years. See, there is a geriatric, according to the guidelines, we can call it as a patient as a geriatric if he is more than 65 years. These are according to the Indian guidelines. But for the Western guidelines, even more than 70 years is also fit. Okay, so whenever you are calling it as a geriatric patient, you have to be very careful. Better to do some geriatric assessment, do some CARG scoring, and then decide what is the chemotherapy associated risk, whether we can deliver this chemotherapy to the patient or not, and then we have to decide. Similarly, the comorbidities, like as I previously mentioned, any long-standing comorbidities like diabetes, which is leading to the diabetic nephropathy or diabetic neuropathy. So these are very, very important, or diabetic. So to decide whether we need to deliver chemotherapy or not. And the third thing is like intensity of the symptom, that is like the tumor burden. So whether the even in the high volume disease, for example, I will give one scenario. So patient has done a scan. There are 3 bone metastases in the vertebra and 1 metastasis in the rib. According to the classification, still it will fall into the high volume disease. But second scenario, like in our patient, there are multiple, like some 20-25 bone lesions are there, studied all over the ribs and the femur, vertebra and the spine, pelvis. That patient is also high volume disease. So again, so it all depends upon the tumor burden. Don't just go by the classification like high volume or low volume. We need to assess the tumor burden and then we need to take a call. And the third thing, important one, is bone metastasis. Rather than, as I mentioned in the previous thing, rather than number of bone metastasis, you need to see like what is the positive area of bone scan. Is there any validated data to measure that percentage of positive area of bone scan? No. All these are in the initial phases, in the development phase. But to in a day-to-day practice, to take the clinical call, whether to add which regimen, these kind of things are more important. And the third thing is like, see, we have to remember that in a prostate patient, metastatic patient, osteolytic lesions leads to the faster progression and reduced survival compared to the osteoblastic lesion. So you need to see all these features, whether the patient has only blastic lesion or lytic lesion. And second thing, coming to the visceral metastasis. Again, visceral metastasis has been associated with the poorest prognosis, highest mortality. Lymph node only metastasis has the most favorable outcome, whereas the combination of bone metastasis and visceral metastasis is the worst one to have. So these are the things you should remember, like the age of the patient, geriatric assessment, comorbidities, not only the comorbidities and its end organ related, any end organ related damage, the intensity of the symptoms like the tumor burden. So where all the disease is, whether these are blastic lesions or the lytic lesions, and then whether any visceral metastasis are present or not. So these factors we should consider. And then coming to the other thing was bulky tumoral masses. So there is an entity, there are multiple studies out there where they have quoted that patient having a Gleason score of 8 or more with bulky lymph nodes. What they mean to say was bulky lymph node was more than 5 centimeter. They have associated with more aggressive variant of prostate cancer and poorer prognosis. So these are the soft indicators. I'm not saying that all these patients should be considered for high volume, but these are the soft indicators apart from the majority of the one. And the second thing is PSA kinetics. See, for example, like if the patient belong to that intermediate group of prognosis, like metachronous high volume disease, you need to see like what is the PSA doubling time, whether it was happened within 6 months or less than 6 months, or within 3 months or more than 3 months. So that also will give an idea like what is the biological, physiological disease characteristic. So depending on that, we can take. And then the important thing, which I have seen recently, like multiple times in my JCs, so like high Gleason score and low PSA value. So what they mean was high Gleason and low PSA was, if the Gleason was 8 to 10, but the PSA is less than 4, they had, in a study, they have found out that they are associated with a higher rates of T4 disease and visceral metastasis, with the shortest median overall survival to 34 months. So these are the conditions which we should look for. That patient has been high Gleason score and low PSA, they would behave aggressively, and you should choose the best regimen, that the triplet. And then the histology, yes, adenocarcinoma and small cell or adenocarcinoma with neuroendocrine differentiation, this but the presence of any intraductal or cribriform growth patterns in the adenocarcinoma component is known to be exhibit a more aggressive clinical course. And similarly, the more advanced ones, so nowadays we are doing NGS for each and every patient, if affordable. So the molecular features like TP53, P10, and RB1 tumor suppressor genes, these are also predictive of the worst overall survival outcomes. Whereas in contrast, presence of the SPOP mutations are linked to the better response rates with ARPI alone. But if this mutation is present, they do not respond better with the they do not respond well to the docetaxel. So these are all the features which you should consider before making a diagnosis of whether you need to choose the doublet regimen or the triplet regimen. So this is the summary slide, how I choose doublet versus triplet in a day-to-day in my clinical practice. So if it is a high volume or a synchronous disease, triplet regimen. Patient is fit for chemotherapy after geriatric assessment, triplet. Significant tumoral mass, that is bulky disease, more than 5 centimeter, Gleason more than 8, multiple tumor, vertebral metastasis and the visceral metastasis. And high Gleason score and low PSA, this is an entity like PSA less than 4 with a Gleason of more than 8. And the mutation status, who are negative for triple, we will call it as, conveniently call it as triple negative in prostate cancer. This is a new entity, like how we say in triple negative breast cancer. So triple negative prostate cancer are nothing but there is a loss of TP53, loss of P10, and loss of RB1. And these patients are like very aggressive tumors, and we need to treat it with the triplet regimen. And similarly, the doublet one were metachronous on the low volume, good performance, poor performance status. There is a poor bone marrow reserve, and there is an end organ damage. So these are the kind of patients where I will choose doublet regimen. So, and other things. So important question was like how to assess the comorbidities. Like there are multiple comorbidities out there, and depending upon the comorbidities, we can choose like we should know like which drug is preferable in those one. Like if a patient is poorly controlled diabetes, if a patient has a osteoporosis, better not to give abiraterone in that patient and prefer the other ARPIs. And similarly, if the patient has a seizure or seizures or seizure risk factors are there, in this one, abiraterone or the docetaxel are the preferred one rather than the enzalutamide. And if a patient has a neuropathy, again, so apalutamide, enzalutamide, or abiraterone are the preferred, and we should avoid the docetaxel. So these are the certain clinical, like soft indicators. So we should know like which drug we should use and which regimen we should use. So for my patients, so what I have done more like we have given 6 cycles of docetaxel along with the darolutamide, and then dagarix was given for this patient. So the compliance was good. The tolerance was excellent. There are no grade 3 or grade 4 toxicity, and there is no delay in the chemotherapy thing. And the response was, there is a serological and radiological excellent response was there. PSA has been came down to almost like 0.008, and PSMA PET has shown that is like near complete response. So all the lesions which are there in the vertebra, you can see like all the lymph nodes, all the vertebral lesion has completely disappeared. And now also patient is on follow-up, and he is doing excellent for the past 1 year. So these are my thoughts on like how to choose on triplet versus doublet. And then among triplet, again, depending upon the side effect profile, we need to choose whether the darolutamide or the abiraterone. And then the thoughts on the daro doublet. See, like, so now the daro triplet is a standard of care, that is agreed. But what about this daro doublet? My only problem with this Arano trial was this placebo arm. See, the intervention arm has like darolutamide plus ADT, but the subsequent like control arm was like only placebo plus ADT. So I don't think that is a sufficient standard of care arm, like control arm. If they have done it with a abiraterone plus ADT or enzalutamide plus ADT, then it would have been a more better trial. But having said that, yes, again, as Dr. Lakshmi Deepti has rightly mentioned out, even if the patient is not fit for chemotherapy like docetaxel, and we have to choose one of the ARPIs, yes, depending upon the drug interaction, depending upon the comorbidity status of the patient, we can consider using this darolutamide. So I don't go into details because other presenters has already told these things. So this is from my side. Yeah, any questions or any thoughts? I just want to have a one-on-one interaction with Deepti and Shravan. Like, what is your take on this one? So how will you choose on the doublet versus triplet in your day-to-day practice, Shravan?
It is exactly the same how you are told, sir. So, depending upon the volume of the disease and again, synchronous and metachronous factors considering, and again, patient factors considering age, comorbidities, and life expectancy. Considering all these factors, the drug is chosen. And exactly all the points which you have enumerated, these are the factors I consider.
Yeah. So my question was like, even this question will strike every time I will write that PSMA PET. So will you define low volume, high volume based on the PSMA PET or depending upon the conventional? Are you using conventional imaging or PSMA PET?
No. It's easy to get PET PSMA rather than we have to getting bone scan is difficult than PET PSMA. So
Yeah.
I go for directly PET PSMA because if we are going for bone scan again, we have to see for visceral metastasis. We need another imaging. Rather than that, PET PSMA is much easier.
Yeah. So why I asked this was, or Lakshmi Dikti, you can answer this one. Why I am asking this question was because if you see that classification of high volume or low volume, they have used only conventional imaging. So what do you think, like by using this PSMA PET, are we upgrading or are we overstaging or over hyping the low volume patients to high volume patients by doing PSMA PET?
Yeah, might be, so definitely. But in future, because because of logistics, we are using here, and later in future, PET PSMA might be the standard of investigation, which will replace bone scan.
Yeah.
And yes, definitely, we are over treating based on that. But anyways, it is going because these drugs have benefits both in the low volume and high volume disease, which is rather helping patient
Yeah.
than I mean which is better to overtreat rather than
Understood.
undertreating.
Yeah. So my thing was like, I don't think even if I am doing PSMA, but nowadays I'm not doing any CT or bone scans kind of thing. But after PSMA PET, the question was like, if there are multiple meds, like how I have described in my patient, so there is no second thought about it. We will go like we will treat it as high volume. But the problem comes like there are only three or four lesions, and there is only one lesion outside the vertebra, and there is one lesion in the limb. So there comes the difficulty, like whether we are dealing with a lower volume disease and we are upgrading it to high volume. So in that scenarios, what I will generally do was like I will still treat it with like an oligometastasis kind of thing and then go ahead with the curative intent kind of thing. So that is my approach in my day-to-day practice.
Yeah, agreed, sir, on that. But I would prefer triplet even in that kind of setting, even if it's 5 meds, which is making it high volume. It is better to hit hard earlier rather than at metastatic setting. We say that overall survival doesn't change, but for patients, treatment-free survival is also very important, which affects their quality of life, psychological things. It's difficult to go through for patients. The number of hospital visits are decreased. They enjoy their life compared to that of in the metastatic setting. Once they record with the disease, then again they do not have proper quality of life. So it's better to hit hard early. And if in that case, definitely I again try to treat them with curative intent, give local radiotherapy, and if there is any residual disease, local radiotherapy also.
Yeah. And Deepti, like between abiraterone and darolutamide, you have to choose. A patient is fit for chemotherapy, you are choosing triplet. So then how will you decide between? Deepti, are you there?
Yes, sir, I'm here, sir. I had some network issues. I was not following what discussion was going, so can you repeat?
No. I'm just like in a triplet regimen. So like you have both the options. So how will you choose between darolutamide and abiraterone in a triplet?
It depends on the patient's other comorbidities, sir, and also definitely affordability issues, sir.
Yeah.
If the patient is already having hyperlipidemia or any hypertension or any like edema and all, I would choose daralutamide. Otherwise, my preferred option is usually abiraterone, sir.
Okay, fine. So even majority of the patients are there if finances are not in constraint, and then only thing was like multiple polypharmacy. Patient is having multiple comorbidities,
Yes.
already using
And
polypharmacy.
also
Then
steroid also it has to be given with abiraterone, sir. So
yeah,
even that would be a defining factor.
yeah. Shravan, any place where you have used darolutamide doublet?
Sir, honestly speaking, I did not get the chance to use it. I want to use it desperately. But
Okay.
see, considering the side effect profile, it's much,
Hmm.
much easier to use. You see, we can avoid hyponatremia, hypokalemia, and definitely if the patient is having polypharmacy and cardiac diseases. Seeing all that, it's very easy to choose drug. But right now, what hinders is basically the cost issues. And
Cost.
if the side effect, basically, if a patient who is not having financial constraints, even with no comorbidities or nothing, I will choose to use Darolutamide.
So fine. So like even from my side also the same. So in doublet, if at all I have to decide between Daro, Enza or the abiraterone, the first thing coming to my mind would be the finances. So the second thing would be the toxicity profile, the comorbidities thing, and then the efficacy. As we know, like any ARPI is like more or less same. So these are the two factors which will play a major role in deciding the thing. Yeah. So yeah, thank you. That's it from my side. If any questions or anything, or otherwise we can close.
That's it.
Yeah, thank you, doctor. So before conclude, sir, let me check any questions in the chat box. So I don't, yeah, I don't see any questions in the chat box, sir.
Okay.
So, sir, can we conclude the session, sir?
Yeah, thank you. Thank you so much
Yeah.
for inviting
So,
all of us.
my
And thank
sincere
you,
thanks
Shravan
to,
and Deepthi.
yeah, please proceed, sir. Sorry.
Yeah, nothing.
Yeah. So my sincere thanks to Dr. Shravan Dubasi sir for discussing our narrations data, and also my thanks to Dr. Lakshmi Deepte ma'am presenting the data on Aranote. Also I thank to Dr. Ravikrishna sir for presenting the case. So definitely sir, we as a company we understand the finances is more concern to the patient where we are getting more inquiries but we are not able to materialize. But definitely we will come back with a better path. As of now, we are having to place this scheme. So very soon we may come up with a better path. So definitely you will be, appreciate the better path which will come in the near future. So thank you so much, sir, and thank you so much, ma'am. With this, we can conclude the session. So yeah, we can end up the session. So I
Yeah.
request technical team to close this meeting.
Thank you, Sandeep. Thank you,
All right.
everyone.
Good night.
Thank you, sir.
Thank
Thank you,
you.
ma'am. Thank you, ma'am. Goodbye. Technical team.